I decided it would be beneficial to talk about a few things before the scenarios that we do in lab. So I'll do this little video which introduces some of the things that some of the teaching points that I'm going to want to hit on during lab on the third. So take a look at this video and especially pay attention to the different concepts that we go over. You won't see every single thing, and again, I may introduce some extra stuff that's not in this video, but this will cover most of the main points that I definitely want to convey with the scenarios that we do in lab. So the first thing that we want to take a look at is narcotic overdoses, and remember that the way that narcotics and um, endorphins work in the body is that they bind a receptor. So here you have the opioid receptor, the opioid that actually binds. It fits in this opioid receptor. So the shape determines the shape of the receptor determines what opioid fits in there. And for the opioid receptors, the pretty much the whole class of narcotics can fit in there. So that could be an endorphin, that could be fentanyl, morphine. The difference is, of course, if we have different shapes of narcotics, they may fit in there a little bit better than others. So opioid binds into the receptor, and then you have some sort of action in the cell. It's not so much important that you know this, it's just that there is a chemical change within the cell when you have a narcotic binding to the receptor. And remember the differences between agonist and antagonist. So an agonist, remember, causes an action. And that's going to be key. We talk about beta agonist, that would be albuterol. It causes an action. The beta agonist stimulates the beta receptors, and there's an action which in the lungs is bronchodilation. The other is an antagonist, and that is what we a lot of times just call a blocker. So we talked about a beta 1 antagonist. That's your LOL drugs or your beta blockers. In this case, we've already talked about the opioid or the narcotic binding the receptors, and it causes an action, which is depicted by the kind of glowing here. But the opioid, which is an agonist, binds the receptor, causes an action. The other side here is that we have an antagonist, which is the Narcan, is going to fit in those binding sites, and when it binds into those binding sites, you get no action, but it just sits there, and then the agonist can't fit into that site, and you can't get a reaction. So in principle, the antagonist is a blocker. In this case, Narcan is going to fit in there and block the opioids from binding into that site, so you won't get that reaction that you want. It's kind of funny for me that when I kind of learned this, remember you're responding to a narcotic overdose, so they already have the agonist bound to those receptors. So how does that work? And the answer is really twofold. First of all, when you have binding of the opioid in the site, it's really kind of a flux. You have lots of binding, and it comes off the receptor. Binding comes off the receptor. Binding comes off the receptor. So there's multiple times when it comes on and off. And so there's an opportunity for Narcan, once we give Narcan, to fit in that site and block it, because it's constantly coming off, it's constantly rebinding. So Narcan will have a chance to fit in there. The other is that Narcan has a stronger affinity for that receptor than the opioid may have. So it will basically stick in there a lot stronger than the opioid may, with a few exceptions. Uh, so speaking of some exceptions, we mentioned that the shape determines that how strongly it binds. So we kind of typically think of the opioid receptors in terms of morphine. If morphine binds that receptor, then we kind of have a standard to think about how strongly something else binds to it. Fentanyl is 1,000 times more potent, which means it might bind more stronger. It also might stay in in a synapse longer. So there's well, that word potent may have multiple meanings. So it might just be stronger. It might cause that receptor to act more strongly inside the cell, or it might stick around longer. But in any event, fentanyl is about 1,000 times more potent than morphine. We have a new drug, W18, which I don't think has kind of come around this area very much. But it's about 100 times more potent than fentanyl, which means it's 100,000 times stronger than morphine. So if you can imagine this drug, which is W18, um, can actually bind to that receptor much, much more stronger. In fact, it may even be much more stronger than Narcan. So you may actually need to give your patient lots and lots of Narcan to reverse some sort of respiratory depression, or your Narcan may actually not work at all. So that's going to be a key point when you're looking at your scenarios. Narcotic overdose may or may not respond to Narcan. So you do have to give it a moment to work, a couple of minutes. But if it doesn't work, then you're just going to manage the patient like you would if you didn't have Narcan, which is control that airway. That's going to be big, and make sure that you're ventilating that patient. All right. So totally switching gears. A lot of patients that, or a lot of calls that we may see are patients with multiple complaints. We kind of talk about, especially in EMT, you have that patient that has COPD and they didn't really have any other complaints, or you have a patient with CHF and they didn't have any complaints. But what are we going to do with that patient who has a history of both? So you get on scene and you can see the patient over here on the side of the screen, where if you notice, tripoding, already on oxygen, looks like she's really working hard to breathe. The other thing I note is that she's got these bruises on her skin. So I'm thinking that maybe she takes some sort of blood thinner, that she bumps her skin and she gets these bruises. Maybe she has AFib, so maybe a history of stroke with that. But also see bandages on her, band-aids on her arm. Maybe she has skin tears and things like that. So I'm going to automatically suspect that she's taken steroids, because that not only can that make the vessels really fragile and prone to breaking, but can also decrease the collagen in the skin and predispose her to skin tears. So she has a history of COPD, CHF, CAD, which is coronary artery disease, and hypertension. There's her medications. Take a minute to look up each of these medicines, because that's going to be important in lab, that you can at least know most of these classes. Albuterol, so she got COPD. Spiriva, which is also a COPD medication. Prednisone, she takes the steroid probably for the COPD. And then we get into CHF, Lasix. She takes a LOL drug, so that's a beta blocker drug, so either for the hypertension or CHF, or even the coronary artery disease. She takes a Pril, and hope you're familiar with the Pril. That's an ACE inhibitor. So also for hypertension, fluid management, things like that. Digoxin. Um, this is a pretty tough drug on the system. She's probably taking it for her heart issues, conduction management, things like that. This one's really easy to get out of whack, and they can be really toxic um, and present with some cardiac dysrhythmias. Lipitor, so that's cholesterol medicine, and then she takes aspirin a day, uh, uh, every day, Q day. So just some review for COPD. We have primarily two forms. We have emphysema. Remember that this is the decrease in the alveolar walls. We can get air in, but the the alveoli collapses, so it's hard to get air out. So we typically call these guys pink puffers because they can get air in, but have a hard time getting it out. They purse their lips to increase the airway pressure to keep the alveoli from collapsing, um, and of course often caused by smoking. So the assessments, because they have that airway trapping, we sometimes get a barrel chest appearance, prolonged exhalation with the pursed lips, of course coughing, diminished breath sounds, wheezing. We may get some rhonchi, some mucus production. So your assessments for your emphysema type patient are pretty much just difficulty breathing with pursed lips, the pink complexion because they can get oxygen in usually, but they have a hard time getting rid of carbon dioxide. Usually these folks are on home oxygen or some sort. Compare that to chronic bronchitis, that is a chronic inflammation, swelling and mucus production here in the lower airways, excessive mucus production. So we get that mucus rattling around. We get rhonchi. These are what we typically call blue bloaters because they are chronically cyanotic and chronically overweight. So we call those blue bloaters. Many times a productive cough because they're producing all that mucus and the rhonchi, and of course we'll get wheezing and even crackles or rales, which is going to complicate your assessments with other comorbidities. And then congestive heart failure, a little bit of review about that. Remember that we get enlargement of the heart, usually due to some sort of chronic hypertension and things like that, which increases oxygen demand, and then and then we get some diseased myocardium, so the heart doesn't pump very effectively. We get some backflow. Um, we get in this case we get the increased hydrostatic pressure from the arteries from into the capillaries, which causes the fluid to shift out into the alveolar space. And this can happen on the with right-sided failure as well, but then we would get this fluid, this increased hydrostatic pressure in the ankles and things, for example, and we'd also maybe get some JVD. Assessments for those, of course, in your acute phase, while you're called for difficulty breathing, tachycardia, anxiety because they have a decrease in the ability to perfuse oxygen. So normally we have to get oxygen from the alveoli through the alveolar wall, through the capillary wall into the blood. Well, if we add fluid to that, now we have another barrier to get through, so it's harder for oxygen to diffuse. So they'll be hypoxic, cyanotic, even harder to breathe, even pale skin, because we have less flow, less oxygenated blood to the extremity or to the skin, and then as we mentioned earlier, we may have swollen extremities because we have that fluid shift out into the peripheral spaces, or we'll have fluid shift into the lungs, so we have crackles or rales, and then even a cough. So, what are we going to do about this patient that has a history of both? How would we differentiate between the two? Is this a CO2 COPD exacerbation, or is this a CHF event? How are we going to decide? And just some things you can look at. COPD will typically be your wheezing and rhonchi, and CHF will typically be your rales and crackles. And honestly, sometimes you'll get some wheezing with CHF. You can get some crackles with COPD. So even that's not clean cut. So we're gonna have to look at some other assessments. And honestly, sometimes it's hard to differentiate between those sounds, especially in the back of the ambulance. So let's look at some other things. With COPD, so looking at that patient that has a history of both, um, I would ask if they've had recent weight gain, like fluid retention, over the past few days. And that, if they did, if they had fluid weight gain over the past few days, that would maybe skew me towards CHF. And then COPD, that patient again, uh, they may not have any JVD or any more pedal edema than maybe they may necessarily have. And then CHF, you may get the JVD and pedal edema associated. The big thing I'm going to look for is that I'm going to put them on capnography. Obviously, if they need ventilatory support, CHF or COPD, I'm going to give them ventilatory support, and they can either one could benefit from BVM or CPAP especially. So the treatments for the BLS treatment's going to be the same. If you need CPAP, give them CPAP. But I'm going to want to decide where I'm going to go with my drugs. Do I need to give a bronchodilator, or do I have a patient that maybe bronchodilation, at least beta agonist, might actually be detrimental or potentially detrimental? So I'm going to really want to know what their capnography is. Again, with COPD, with wheezing and things like that, you're going to see that anytime you have bronchospasms, you're going to have the shark fin waveform. With CHF, the issue is not bronchospasm. The issue is the fact that we have fluid buildup in the alveoli. And again, you can have both, but if we're trying to make a distinction between COPD and CHF, look at their CO2. And in this case, remember, fluid in the lungs. It's hard for oxygen to diffuse from the alveoli into the blood, but it's also hard for carbon dioxide to diffuse from the blood into the alveoli. So in this case, she's hypercarbic, and you see these big box waveforms. There's no bronchospasms on the bottom example. On the top example, she's got shark fin waveform, so I would more suspect COPD. So let capnography really help you determine these patients. So treatment for COPD is going to be oxygen, albuterol, Atrovent, steroids, CPAP if we need. With CHF, especially if she's not hypotensive, she could get CPAP, nitro, maybe even nitro paste. And the issue there is, why can't we just give them everything, cover our bases? And the issue is that CHF is up to 50% of the patients may be given albuterol inappropriately. Does that make a difference? Well, there is a significant body of evidence, as this paper says here, that some patients administered with a beta-2 agonist, such as albuterol, may be at increased risk of adverse events such as dysrhythmias, heart failure exacerbations, and increased mortality. So, given albuterol is not without its risks. So, and this patient is going to be really hard. Is it COPD or CHF? And again, if they have a history of COPD but not CHF, I'm probably gonna skew towards COPD, but don't let that be the end all be all, because they could have a new onset CHF, acute pulmonary edema type situation as well. So uh, do your other assessments as well and get a complete clinical picture, including the capnography. Weight gain. Have they been sleeping with more pillows? That would skew me towards CHF, fluid buildup, that sort of thing. So get a good do a good assessment on these patients, get a great clinical picture, and treat appropriately. Sometimes we're not going to know, and sometimes we're going to give albuterol when they shouldn't have, and honestly, sometimes physicians are wrong too. So, but the take-home message is you can get more information just by doing a more thorough assessment. All right, so looking at altered mental status, so we'll have a patient tomorrow night that has altered mental status. That's going to be pretty standard. Remember things that the brain needs: oxygen, it needs glucose, it needs to be hydrated to work effectively. Causes of altered mental status are deficiencies in oxygen and glucose hydration to the brain tissue, some sort of trauma, infection, some chemical toxins harming brain tissue, and then stroke, or other, or hypoxia due to other systems. For example, you have a patient that has asthma, they get hypoxic, they may have altered mental status. A way to remember some of these things is AEIOU tips, and this is just a graphic of some of these: alcohol for epilepsy, for maybe they had a seizure; insulin for diabetics; overdoses for other toxins and things like that; uremia, so maybe they have some sort of renal disease, or they missed some dialysis appointments because it was snowing, whatever; and then trauma, and then toxins, infection for the other eye, as psychiatric or poisons, and then stroke, or also space-occupying lesions like a subdural hematoma that they might have going on, or a subarachnoid hemorrhage. So do a thorough neuro assessment. So the first thing I'm going to do is I'm going to check the head for any DCAT BTLS. Maybe they've had a head injury. This medical altered mental status, it could be a trauma patient. So I'm going to look. I'm going to look for old bruising. Remember, old bruising, brand new bruising is red, then it gets purple, and then as it heals, it kind of turns this yellowish green color. So just different stages of healing, and it may be a couple days old, it may be a week old that they've had that they've had the injury. I'm going to look at the eyes. In this case, you have this disconjugate gaze, where one eye is looking a different way. And then look at pupils. Pupils may be able to tell you. In this case, you see the dilated pupils, maybe a cocaine or some sort of sympathetic stimulant causing with this dilated pupils, or the pinpoint pupils here, and then of course unequal pupils. That would, if I see unequal pupils, I'm thinking that there's some sort of brain bleed or head trauma going on. But the pinpoint pupils could be a narcotic overdose, or a exposure to some sort of like a nerve agent or cholinergic agent. So start with looking for DCAT BTLS in the head, looking at the eyes, pupils, and gazes and things like that, reactivity. I'm going to look at the eyes. It didn't come through, but nystagmus is where the pupils, where the eyes kind of go back and forth. They would go in unison here, but they kind of rove back and forth, and that would tell me head trauma or alcohol intoxication, or they're actually having a seizure, And yeah, your patient could be having a seizure and not have the typical convulsions that we think of. They could be having a seizure and just look at their eyes and they're having this nystagmus kind of going back and forth. So that's also a consideration with the eyes, is nystagmus. For other neuro assessments, this is not on here, but check PMS. That would be totally appropriate in all four extremities if you need to. The other is we're familiar with a FAST exam, so do a stroke exam. This is also called the Cincinnati Stroke Scale. I hear sometimes providers say they don't, at least in some of the documentation, some of our computer documentation, we have Cincinnati Stroke Scale, and I've heard providers say, well, I don't know how to do a Cincinnati Stroke Scale because I've never been trained on it. But yes, you have. It's just the FAST exam. So F is for face. Do they have an uneven face, and because we're a little bit more medically inclined, we can actually get them to smile if it's not clear and look for unevenness. A is for arm drift. Is there weakness in one arms or both? And remember, this is where we actually have them close their eyes and put their palms up and hold them there for 10 seconds. And if you get one droop down, remember palms up. If you get one drifting down, that would be a positive, or they can't hold it up altogether. That would be positive. Speech, is it slurred? They having trouble? They seem confused. So any speech issues in time. So that's the FAST exam, but we've actually added a couple pieces. So the BFAST exam, and the other is balance. Do they have any balance issue? And then E for eyes, any vision changes or loss of vision in their eyes. So the BFAST exam is a little bit more thorough. If you can imagine the balance, that's the cerebellum, and then the E eyes is the occipital lobe. If we don't think about those, we might actually miss strokes in those areas of the brain. All right, so maybe capnography can help. By the way, it's always a good idea if you have a patient with altered mental status. Always use capnography with difficulty breathing and altered mental status. Always, always, always. And the idea is it's so much easier for capnography to see ventilations with capnography than it is to notice that very shallow or normal, even chest rise and fall. It's really easy to have a patient that is seemingly breathing okay, and then they actually change. They decompensate and they stop breathing very adequately, and you just don't notice it because you're in the back of the ambulance. You got 1,000 things going on. You're trying to document, blah blah blah. So capnography is just the best thing you can do, especially if you have an altered patient or a patient with difficulty breathing. What would it tell us? Well, it could tell us, go back to AEIU tips, it could tell us some things about are they CNS depressed? Hypercarbic would mean they need to be ventilated. High carbon, big boxes, means they're not breathing adequately, bag them. Or CPAP if they're tolerated. Hypocarbic, meaning they're breathing fast, and that might be some sort of metabolic issue. Remember that DKA patient we had last week? They had hypocarbia. The carbon dioxide was low because they were breathing off too much. So maybe they have some sort of metabolic issue. Remember, some other things create acid, like lactic acid, aspirin overdose. They might be breathing fast to compensate for something like that. Normal, it doesn't tell us anything particular except that they don't have a metabolic issue and they're ventilating okay for the moment. With altered mental status, especially in our elderly patients, especially with patients that have had a stroke, so they're not mobile as much, and maybe they have to they have some sort of urinary issues as well as eating, the swallowing issues, prone to pneumonias and UTIs and things. Definitely always consider sepsis, especially in your elderly population with altered mental status. First thing I would do is assume or check for some sort of toxic overdose, especially that patient that has digoxin. Do they have severe bradycardia, things like that. The other thing I would do is check for sepsis. If I can't find anything wrong with this altered mental status patient, uh, I I might assume a stroke. But then if they don't have any of that Cincinnati stroke scale, I'm going to assume sepsis. All right, so there's a continuum of sepsis. On the one end, there's what we call SIRS or SIRS criteria. So you need at least two of the following, and of course, white blood cells we're not going to find. So if their respiratory rate is more than 20, and by 20 we don't mean the laziness that we typically fall into, where, oh, what's the respiratory rate? 20. Now, if you're writing 20 on your call sheet for every patient, you're doing something really wrong. So 20, remember, is the high end of normal, so they should not be 20. But higher than 20, that is one SIRS criteria. Uh, Tachycardia would be a second SIRS criteria. And then if we can, if they have an elevated or a low temperature, that would be another SIRS criteria. So if they have a fever, tachypnea, and tachycardia, that's three of them. They have SIRS criteria. To be septic, then we need to look at, do they have some sort of presumed or confirmed infection. So they have been incontinent, urination of peed over the cells. Maybe it's had a strong smell. They have recurrent UTIs. They always have a problem with this. They have some sort of pneumonia. Those are going to be your big ones. And then any other type of, yes, they've had infection or some sort of infectious disease over the past week or so, colds, flus, things like that, then there's your source. For what we call severe sepsis, is sepsis with some sort of organ failure, so usually kidneys or lungs or whatever. But these patients are going to need lots and lots of fluids. For septic shock, we really won't call it septic shock particularly until really it's refractory hypotension, so it doesn't respond to fluids. And for the purpose of pre-hospital, you got a patient that's hypotensive, I would, they're septic shock. But anywhere in this continuum, you can call them septic. And it can cause, if they're altered, if they have a SIRS criteria with you think they have some sort of infectious disease, and they have altered mental status, that's organ failure. That means the brain is not getting perfusion, so that's severe sepsis right off the bat. So they need lots and lots of fluid. All right, so that's the synopsis for the lab. Think about those three patients. If we have time, I'll add a fourth patient, but those are the three patients I definitely want you to start thinking about and start learning some of these very important key points from. All right, hope you have a good night.